All right. Hey, everyone. If you're a med student heading into your clinical years, listen up. There are some drugs you just have to know, like the back of your hand. Today, we're going to tackle one of the big ones, a super critical emergency med you'll definitely see, naloxone. So let's jump right in.
So, here's how we're going to break it down. We'll follow what I like to call a bench to bedside approach. We'll start with the science, the nitty-gritty pharmacology of how naloxone actually works. And then we'll shift gears and get super practical, talking about how you're going to use it on the floor, at the bedside, safely and effectively.
Okay, first things first, let's really nail down the basics. What exactly is this drug, and what's its whole purpose?
So, naloxone is what we call a pure opioid antagonist. The easiest way to think about it, it's literally the anti-opioid. Its one and only job is to march into the central nervous system, find the receptors where opioids are hanging out, and just kick them off. And it doesn't stop there. It then blocks those receptors so the opioids can't get back on. It's not activating anything, it's purely playing defense. And in doing so, it completely shuts down and reverses the effects of the opioid.
Okay, so when do we actually pull this drug out? Well, its number one, top of the list, life-saving job is to reverse respiratory depression from an opioid overdose. That's when someone literally stops breathing. But it's also a pretty amazing diagnostic tool. Picture this. You've got an unconscious patient in the ER. You have no idea why. You push some naloxone and boom, they wake right up. Well, you've just diagnosed an opioid overdose. It's that powerful. We also use it in other settings, like waking patients up from opioid anesthesia after surgery, or for tackling overdoses from some really nasty synthetic stuff. All right, so we get what it does, but how does it work? Like down at the molecular level? Let's zoom in a bit and look at the mechanism of action.
This is what we call competitive antagonism, and it's basically a battle for the same receptor. Think of the mu-opioid receptor as a prime parking spot. An opioid, like morphine, is already parked there, causing all its effects. Then along comes naloxone. Naloxone has a much higher affinity for that spot. It's got a stronger pull. It's like it has a VIP pass to that parking garage. It just swoops in, boots the opioid out of the spot, and then parks itself there. And while it's parked, it does nothing but block the spot, effectively flipping the switch for that cell from on to off.
Now, you've got a few different types of opioid receptors, mu, kappa, delta. They all do different things, but the one we really care about here is the mu receptor. Why? Because that's the main one responsible for that super dangerous respiratory depression, the thing that kills people in an overdose. Naloxone's superpower is its incredibly strong blockade of that specific receptor. By shutting that one down so effectively, it gets the patient breathing again. Simple as that.
Okay, so let's track this drug's journey through the body. This is what we call pharmacokinetics, or ADME. You'll hear that a lot. It stands for absorption, distribution, metabolism, and excretion. And trust me, for a drug like naloxone, timing is absolutely everything.
Just look at this timeline. It shows you how incredibly fast this stuff works. If you give it IV, intravenously, it kicks in within 1 to 2 minutes. That's amazing. It hits its peak power in about 15 to 30 minutes. But, and this is the huge but, the critical catch, look at its duration. It only works for about 60 to 90 minutes. I want you to burn that number into your brain. We're going to come back to why that's so important.
I really want to hammer this point home. 1 to 2 minutes. In an emergency, when someone isn't breathing, that speed is everything. We're talking about the difference between a patient making a full recovery and having permanent brain damage from a lack of oxygen. It's that serious. And now for the other side of that coin. That 60 to 90-minute lifespan, it's incredibly short. Think about it. Many of the opioids we're trying to reverse can last for hours. This creates a really dangerous mismatch in timing. And this little factoid right here, well, it's the key to the whole thing. It's the foundation for our clinical pearl at the end, so don't forget it. Okay, naloxone is obviously a life-saving drug, but that doesn't mean it's risk-free. When you slam the brakes on an opioid's effects that quickly, you can run into some pretty big problems, especially with certain types of patients. Let's get this out of the way first. The bottom line is, if someone is dying from an opioid overdose, you give naloxone, period. There are no absolute contraindications. Even in a pregnant patient, you save the mom. Now, with that said, you do have to be a little careful. In someone with a history of heart disease, that sudden jolt can cause issues like high blood pressure or a racing heart. But really, the biggest thing you're going to see and you will see this, is what happens when you give it to someone who is physically dependent on opioids. For them, naloxone will trigger an immediate and really severe withdrawal syndrome.
So what does that actually look like? It's really important to know what to expect, because honestly, it can be pretty dramatic and frankly upsetting for everyone in the room, the patient most of all.
The best way to describe it is that you're basically giving the patient the worst flu of their life, but it hits them all at once in a matter of seconds. They get super agitated, anxious, their heart starts pounding, they get terrible stomach cramps, nausea, vomiting, muscle aches, the whole shebang. Now, let's be clear, this isn't going to kill them, but it feels absolutely awful, and you can expect your patient to be, well, pretty unhappy and possibly very agitated.
Okay, let's make this real. Let's put all the pieces together. You're standing at the bedside. You think you're looking at an opioid overdose. What do? What are the steps? Okay, here's the protocol, step by step. First, you assess. You're looking for that classic triad. Their breathing is slow or stopped, they've got those pinpoint pupils, and they're not responsive. Check, check, check. Next, you administer the drug, usually 0.4 to 2 milligrams IV. Now listen closely, because this is a huge point that people get wrong. The goal is not to get them sitting up in bed, wide awake and yelling at you. The goal is just to get them breathing on their own again. We titrate to ventilation, not to consciousness. And once they're breathing, your job is not done. You have to monitor them, constantly. So what are you looking for? Think before and after. Before you push the drug, you get your baseline. What's their respiratory rate, their O2 sat, their level of consciousness. Then after you give it, you're watching for a few key things. First, obviously, has their breathing improved? Second, are they showing signs of that gnarly withdrawal we talked about? And third, and this is the most important one, you are watching them like a hawk to see if they start to get sleepy again as the naloxone wears off. All right, we've made it to the last and arguably the most important section, the clinical pearl. If you forget everything else we've talked about today, please, please remember this one thing. This is the detail that shows up on board exams, but way more importantly, it's the detail that will literally save someone's life in the real world.
And here it is. It's all about the half-life mismatch. Remember how naloxone only lasts for 60 to 90 minutes? Well, the opioid that caused the overdose, like heroin or fentanyl, can last for hours. So what does that mean? It means the patient wakes up, they seem okay, and you might think you fixed the problem, but you haven't. The naloxone is going to wear off long before the opioid does. And when it does, that patient can slip right back into a coma and stop breathing again. They are not cured after one dose. They are not safe. They have to be monitored for hours, sometimes needing another dose or even a continuous infusion. So I'll leave you with this question to really lock it in. Your patient looks great, they're awake. Why can't you just let them go home? Because the enemy, the opioid, is still lurking in their system. All it's doing is waiting for the shield, the naloxone, to wear down. And your job as the clinician is to stand guard until you are 100% sure that the danger has passed. And that's our deep dive on naloxone. Thanks so much for tuning in.